May I invite Dr. Thomas Paul from CMC Vellore to talk about the current treatment and strategy for optimizing bone health. That is very important, optimizing bone health.
Yes. Can I start? Thank you, chairpersons, and once again thank the team, organizing team, for the warm invitation and warm welcome. The Kolkata is known for this because we get in CMC Vellore, we get patients from West Bengal very, very respectful and very, very warm. Thank you so much. So next about 16 to 17 minutes, I just go through the agents. Like, this is like a review rather than anything like which it's known. 80% we already know. So now we know that fragility fractures, we know 50% of the Indian postmenopausal women are osteoporotic, 40 to 50. And especially when you look at secondary osteoporosis or primary osteoporosis, they have a worst impact on the health of the patient. Many times the fractures are asymptomatic, especially pertaining to osteoporosis is asymptomatic. Even spine fractures can be asymptomatic. Management is addressing the risk factors for fall and fragility for the treatment. Now, I just wanted, this is a very busy slide, I don't want to go into that, but one thing which Dr. Kripa and Dr. Nitin mentioned, that we should never miss fasting serum phosphate. Sometimes, we may miss hypophosphatemic osteomalacia, which will be projected as fractures and osteoporosis. We should never miss. And somebody you are going to initiate on teriparatide, better to measure PTH before starting, because somebody will have a secondary hyperparathyroidism, and that case, if you give teriparatide, may not work. So that is the two things. And if possible, you should have a bone turnover markers, bone resorption marker, CTX, and bone formation marker, P1NP. And after 65, almost all patients should have a VFA, vertebral fracture, or X-ray lateral spine to see any spine fractures are there. These are the few points. Now, when do you treat? Use for treatment, osteoporotic medications for treating and also for preventing bone loss. Vertebral fracture, somebody has got a prevalent vertebral fracture. Anybody has got a T-score of less than 2.5. And if somebody has got osteopenia and additional risk factors, diabetes, we take a little higher cutoff. In certain disease states, many of the rheumatological conditions where you give treatment and the disease per se or treatment causes bone loss, prophylactically we give anti-osteoporotic medication, and we have a FRAX score and decision making. In Indian cutoff, we use a FRAX. It's an online tool. We take a cutoff, maybe 10 for major osteoporotic fracture, and maybe about 2.5 for the hip fracture. Now, this is very important. Fall prevention is very essential. Structured physical activity is very essential. Dr. Nitin was talking about sarcopenia. As the age advances, sarcopenia becomes very common. And optimize the calcium intake and optimize the vitamin D, cholecalciferol intake. This is the definite recommendation for all people, whether they have osteoporosis or not. Now, if we talk about medications, anti-resorptive, anti-remodeling agents, only two we talk about. One is bisphosphonate, next is denosumab. When we talk about anabolic agent, we talk about teriparatide and abaloparatide, but abaloparatide is not available. We use teriparatide as mentioned earlier. It's going on for last 10 to 15 years. And we use other agent, anabolic and anti-resorptive. Both are there. That is romosozumab. That is 25,000 rupees per month, once a month injection. That is quite costly. That is another agent. When we talk about fracture reduction with these agents, vertebral fractures and non-vertebral fractures come down when you use. But we have to be aware that when you use oral bisphosphonate ibandronate, It doesn't protect you against hip fracture. That we have to be aware of that. Hip fracture protection is not there with ibandronate. So if you are considering somebody has got a hip osteoporosis and giving medication, bisphosphonate, please don't use ibandronate. So somebody has got a prevalent fracture. Somebody has got a prevalent vertebral fracture. We prefer to use anabolic agent as first. That is teriparatide. In somebody has got a severe osteoporosis and multiple vertebral fractures, if facility approves, then rituximab we can use. All the other agents followed by. Somebody has got a prevalent hip fracture, we can use either denosumab or zoledronic acid. Teriparatide comes little lower. Somebody has got only osteoporosis, then but high risk for fractures, we can use zoledronic acid or anabolic agent teriparatide and denosumab. Somebody has got a low risk, then we can use even oral bisphosphonate. Now, the fracture risk reduction when you give agents, it is between 30 to 70%. Highest for rituximab, especially spine fractures. Now, when this is a common drug we use in clinical practice, somebody has got a fragility fractures, bisphosphonates, they are good, cost effective. Currently, we use zoledronic acid as low as 600 rupees per year. So it's very cost effective, long term, because it stay in the bone. If you give one dose, it will be there for 2 to 3 years also easily. So the one thing, somebody is receiving bisphosphonate for 3 years or 6 years, the BMD may go up to 6 years, 5 to 6 years. After that, if you continue bisphosphonate, it remains like that. It doesn't go further. So many cases, after 3 to 5 years, we give a holiday. That is bisphosphonate holiday. Now, what about atrial fibrillation in elderly? The opinion is widely varies, and meta-analysis say atrial fibrillation is the increased risk. Some people say it's no increased risk. So what we suggest is, if somebody has got a structural heart disease, you may defer using bisphosphonate, especially zoledronate. You can use denosumab or other agent. Oral bisphosphonate, this is very clear that esophageal problem, not able to CKD less than 30 ml. IV bisphosphonate can cause hypocalcemia, not very severe unless patient has got a CKD. And more duration we give, there is a risk of atypical femoral fracture. Risk is very minimal. And now when somebody on bisphosphonate for more than 3 to 4 years, somebody gets a groin pain or hip pain, look for impending fracture. Or somebody was asking about total alkaline phosphatase. If the total alkaline phosphatase drops below 40, please stop it, because bone has gone into adynamic state. Now, many of us feel when we give IV bisphosphonate or oral bisphosphonate, especially IV bisphosphonate, they get cytokine reaction, fever, body pain. What we can do is, this is what we practice in my center, that is we give oral dexamethasone. On the day of zoledronic acid, next day also we give dexamethasone, next day. It's all oral, 2 to 4 milligram. They bring down the acute cytokine related body myalgia, fever significantly. Now, when you give holiday, like after 3 to 5 years, then if the fracture risk remains high, better to go for an alternative agent, or you may continue bisphosphonate. Now, somebody has got a continuously having a clinical fracture, BMD in osteoporotic range, BTM, bone turnover, resorption is still high, and sometime patient is going to be on steroids, still significant osteoporosis, you have to consider denosumab or teriparatide when you have done with bisphosphonate for 5 years. Now about denosumab, we know that it is a rank inhibitor, and we have data for 10 to 12 years, and it is very good for fracture risk reduction. Once in 6 months we give, that is 60 milligrams subcutaneously. Of course, most of us would have used it. And what is the advantage over zoledronic acid? The fracture risk reduction starts early. as early as 3 months. When you give denosumab injection, the bone turnover marker, if you check the next day, it gets suppressed. It's very fast. Whereas bisphosphonate, it takes time. So somebody got a very high risk for fracture, you may start on denosumab. Now, fracture risk reduction percentage for vertebral fracture, hip fracture, non-vertebral fracture, it's not very much different between bisphosphonate or denosumab. Why I'm comparing the denosumab? Currently, generic one is about 4,000 to 5,000. We are talking about 10,000 per year, whereas we are talking about zoldronic acid about 600 rupees per year. So there is a lot of money. So that's the reason we are comparing. Now, in contrast to zoldronic, denosumab BMD keeps on increasing. I told you zoldronic, after 5 years, the BMD remains static, whereas denosumab, it can go up. Now, somebody has got a significant cardiovascular disease, preferably start on denosumab rather than zoldronic acid. Now, we always know for last 10 years, the moment we stop denosumab, there is a rebound vertebral fractures, which was more pronounced during COVID time. So somebody receives denosumab for more years, like more than 6 to 8 doses, 3 to 4 years. If you stop it, the risk of rebound fractures are more. So what we always say, if somebody receives denosumab for 3 to 4 years, always you give zoldronic acid. If the patient has received denosumab for more years, you have to give 2 doses of zoldronic acid at 6 monthly interval, not every year, so that the bone turnover is. So rebound vertebral fracture, whenever we are stopping denosumab, it has to be bisphosphonate. Rarely we give teriparatide. Teriparatide has been there for more than 1 decade, 20 microgram daily for 2 years. Especially somebody has got so many vertebral fractures or very severe osteoporosis, we tend to start with this anabolic agent. Now, when you start teriparatide, in many global setting, the fracture risk reduction starts as early as 3 months. So that is the good thing about teriparatide, an anabolic agent. When somebody has got a significant spine osteoporosis or spine fractures, we can start on teriparatide. We know that sclerostin is attacking the WNT pathway, and especially it will do away with osteoblast. If you block sclerostin, the osteoblast anabolic activity goes up and resorption comes down. So it is a dual agent. It increases the anabolic activity and reduces the bone resorption. So we have romosozumab. It has been there for last 1.5 years. Professor Chada has been using it for many patients. Our experience is limited. I used only in a couple of patients. So it is good. Frame study was the first study. Our center was part of the study. Romosozumab is very good, especially spine. It increases the BMD so much when compared to teriparatide. It's an anabolic and anti-resorptive. Even in ART study, when it was compared with an anti-resorptive, it is doing very good. Now, there is always concern. When we are part of the frame study, Dr. Nitin, in safety committee, drug safety committee, we had 2 patients with stroke. So there is a concern about increased risk of stroke when you give romosozumab in people who are high risk for atherosclerotic disease. So they say, if somebody had a vascular event in last 1 year, that is the cardiac or brain stroke related thing, better not to use. Otherwise, we can use it. We also wrote a small letter to editor to Osteoporosis International. Is it contrast with pioglitazone? Now, if you look at the agents, abaloparatide anabolic, teriparatide anabolic, romosozumab anabolic and anti-resorptive, the increment is so much. Now, when you compare anabolic agent versus bisphosphonate, we all know that anabolic agent will definitely do better, especially somebody has got a spine osteoporosis and vertebral fractures. Now, there are some entity called combination therapy and sequential. Very rarely we combine anti-resorptive with anabolic, various permutation combination, or many times when we are giving anabolic agent, it has to be followed by anti-resorptive. When you give anti-resorptive like a denosumab, we have to follow with another anti-resorptive. So these are all the various combinations you can do, whether when you have a teriparatide or romosozumab, it has to be followed by denosumab or bisphosphonate. Denosumab, we spoke about rebound vertebral fracture, soldronic and teriparatide. Bisphosphonate, when you if you are going to stop and fracture risk is high, we are going to give either anabolic agent or denosumab. Now, Indian context, this is what the cost is. 600 rupees per year. Cost of teriparatide, generic one is 48,000 per year. And we have used, whatever publications we have is from the generic one. And currently, denosumab varies from 12,000 to 28,000. Romosozumab, what we are getting it about 28,700 to 28,000. So 3,40,000 per year. Once a month injection, romosozumab. Now, I'll give one case. It's a perimenopausal lady, 44 year, and she came to us with a 10 centimeter height loss over 10 years. Her, 90 and all that was sweeping the floor. That's how. She was 160 and she has become 150. She was evaluated. She was given IV bisphosphonate followed by oral bisphosphonate. And she was obese. Height was 150. That's how she came. No OA or no secondary cause, obviously. We did OA genetics to a negative. Now, patient has received zoldronic acid, so bone turnover was suppressed. So what we did was we started teriparatide, anabolic agent, so that whatever the bone can gain. At the end of 1 year after teriparatide, she further lost the height, 2 centimeters. We were wondering what to do. We were also doing the bone turnover marker. So what we did was, you can see the BMD, and we can see this was shown also by Dr. Kripa. At the end of 1 year, the bone formation was going high, but bone resorption was also going high. So what we did, we gave a dual therapy. We continued teriparatide, we added denosumab, so that we are blocking resorption and we are continuing bone formation. After that, after finishing total 2 years of teriparatide, we maintained only on denosumab. Now, she has been transitioned after a few doses of denosumab, transitioned to zoldronic acid. Why I am showing is, this is sequential therapy as well as dual therapy in a selected setting. She hasn't lost the height. She has been on follow for last 8 years. In fact, she had come in 2025, which I put it. She's having 148 centimeter, selected setting. So I like to summarize, choice of the agent depends on the clinical setting and risk factors. Cost, compliance, intolerance have to be taken into account for decision making. Somebody has got a flu-like reaction with zoldronic acid, we can always give dexamethasone. Fall prevention, physical activity, and calcium and vitamin D are very important for optimizing bone health. Thank you so much.
Thank you very much, sir. May I ask one question?
Yes, sir.
Because we are see lots of patients of thalassemia, particularly threats, and they are very, in the early part of their life, even they produce some form of fractures with a high iron content in the blood and low hemoglobin. Is there any difference of treatment policies for them from the elderly who have got osteoporotic fracture?
Sir, actually we have 2 studies. One we have done in hemophilia and the other one is in thalassemia along with hematology. And if they have a significant bone loss and fractures, we prefer, if they are over 18 years, we give teriparatide to start with. Then we give oral bisphosphonate. If they are below 18 years, we are giving bisphosphonate. Not much of denosumab we are used below 18 years.
What is the result of your therapy?
Sir, we have got a follow-up only up to 2 to 3 years. So they are good, sir. They are good.
So is it
Professor
what?
Paul,
Sir.
we have got a case who is 85 years, a senile osteoporosis, non-diabetic. And she had tried 5 years of denosumab.
Yes.
Previous to that, on oral bisphosphonate. Yes. Since she refused to take the teriparatide every day, she preferred to anti-sclerostin.
Yes.
And we have completed 1 year. But in spite of all this, she is giving 4 times fracture, either femur or the hip or the spine or the tarsal bones. And this is a very refractory case. And ultimately, she has agreed to go for the teriparatide once daily for 2 years. And these are the cases, particularly senile osteoporosis. The standard rule of protocol does not always follow.
Yeah, it doesn't work.
And we have
Yes,
got a difficult
yes.
case to treat.
Yes.
And this is a very illustration we have got at the moment of treating that. And these are occasions. And second question is that a patient, which patients are suitable for switch therapy? That is particularly combination.
Yes, sir.
That indications of combination
Yes,
therapy, that is very useful. And patient continue teriparatide for 2 years and every 6 months denosumab. The results are fairly good in order to show that we don't have the rebound effect as we see in the denosumab.
Yes, sir. So the second question is, we are using dual therapy in only selected setting. When you are starting anabolic therapy and we find the response, optimal response is not there, we are adding antiresorptive. Most of our setting, in few patients, we have added denosumab as a dual therapy. The first question, we also find about 5% of the patients, despite giving all this, we find it very refractory. We don't have an answer. Whether to give dual therapy, I'm not sure, sir. We are not done. But in a second question, yes. Correct, sir.
I
Thank you.
wanted to ask you, you've said a lot about the drug therapies, but you give a lot of advice on lifestyle
Yes,
modification.
physical
diet.
activity. Yes.
And the second thing, how do you re-stratify and how do you decide on what course of therapy for which patient to give? Do you have any practical guidelines?
Yes,
What
basically
agent to choose?
for a guideline with relation to the medication, yes, medications, that's what I showed. Somebody has got a spine predominantly, we want to give anabolic to start with. Either omoxicimab or teriparatide. Somebody has got a hip, doesn't matter, whether denosumab or zoledronic acid or okay, anabolic also. That is
If the floor has got any comment or yes?
Any question from the house?
Use the mic. Two patients. One, that of mine, and another, the case was,
Yes, sir.
came to me after there is a tumor in the tongue. Have anybody have noticed? But in literature found there may be some small fibroma in the lung. In the tongue.
tongue, yes, sir.
Tongue. Have you any such experience?
So I used only few patients. Professor Chada has used in 25 patients. Do you have any experience? No, sir. We don't have any experience. Yes.
We are producing designer estrogen. Do you think the denosumab or other anti-osteoporotic drug can replace designer estrogen?
No. No. But thing is, our protocol in our menopause clinic is we don't use unless they have a very transiently we are using menopause HRT after 45. Mostly if they have osteoporosis, we are using the agents. Before 45, yes, we are doing the HRT, but these agents may not have the same effect. We will wait and see the DEXA after 18 months and see.
Is there another person?
Sir, my question is, I have two questions actually. One is regarding LSC. Actually, LSC is not done anywhere, practically in private setup. So, what to do about that? How to practically approach by doing serial BMD, whether it is going to help?
No. We are not covered that for the want of time. We have to have a CV. See, that is a basic thing. That is a standard. So, because our center we do CV, we have 2, 3, how many technicians? We have 4 technicians. We do. So CV and LSC are very, very important. If we don't have, we have to take 2.77 into CV, we'll say about for a spine about 1.5, for a hip about 2%. And if the changes with the therapy is more than, we can call it as significant.
Thank you. No more questions. We are running out of time. Thank you, Professor Pal, for your kind presentations.
Thank you.
Over to next case.